Thanks for joining us here today. Welcome to the Sonosite Behind the Scan webinar called Ultrasound Evaluation of the Anterior Knee. This is part one of a three-part series about the knee. My name is Chris Pennell, and I'll be moderating today's webinar. Before we begin, please be advised all attendees are muted. We'll conduct a Q&A session at the end of the presentation and demonstration, and you can type your questions into the Q&A box in the toolbar located at the bottom or the side of your screen. This webinar will be recorded and archived for future reference on our webinar's website. You can see the link for that on the screen right now. Here with us today, we have Daniel Shelton. Daniel is the Director of Musculoskeletal Market Development for FUJIFILM Sonosite. Daniel has spent 18 years as a dedicated musculoskeletal sonographer, and 12 of those years have been here at Sonosite. He now leads the musculoskeletal market development, and he works to spread the word about the benefits of point-of-care ultrasound. Thanks for being with us here today, Daniel. I'll let you go ahead and get started.
Thanks, Chris, for that introduction. We'll go ahead and get started. This is part one, as we mentioned, of a three-part series. Today we're going to talk about the anterior knee. The objectives of this webinar are not comprehensive, but we will be identifying the major tendons and ligaments of the knee. We should be able to detect a joint effusion, identify injection locations, and also identify the outlines of the suprapatellar recess. We'll be describing various pathologies of the tendons, the joint recess itself, and the cartilage in this particular part one. Today, we're going to talk about the suprapatellar region, the quadriceps tendon complex, the suprapatellar bursa / recess of the fat pads, and the infrapatellar tendon, Hoffa's fat pad as well. First, as you can see in the photograph, we're just going to start at the patella, and then we're primarily just focusing on this mid-sagittal shot to assess the quadriceps tendons complex. And we're really looking at the enthesis here, right along the patella. There's three distinct, almost flat facets on the superior part of the patella. It's prominent in just about everybody I come across, but not all the way across the patella, just in one segment. We'll cover that in the live scan here, but the most superficial component here is number 3 here, which is the rectus femoris. The number 2 here is the complex of the vastus lateralis and medialis, and then number 1 here is the deepest layer of the quadriceps tendon complex, which is vastus intermedius. Moving down to number 4, this is the trochlear hyaline cartilage, and it is anechoic. It's not compressible, so don't confuse that for fluid. And note here, the photograph is not quite as bent as we need, and we'll show that in the live scan. But to get a good tight tendon, it's important to go ahead and put the knee into quite a bit of flexion if the patient can tolerate that. But also in this image here, we have the distal femur and the proximal patella. Now let's talk more about the recess itself. This cadaver slice was probably the most illustrative for me to learn and just show how large and far proximally running this recess is. So the knee joint is a large target, but there's no need to run a needle near the hyaline cartilage, whether you're going subpatellar with your needle or if you're going infrapatellar and driving the needle under Hoffa's fat pad, hoping to hit the recess there. You could be scuffing cartilage at that approach too. So we stay in the suprapatellar recess for knee injections, and we'll actually cover ultrasound-guided procedures, including knee injections, in a subsequent webinar later in the quarter. But for today's purposes, I do want to outline and get everybody comfortable and confident with suprapatellar recess anatomy here. So number 1, back to review the patella. Number 2 is the shaft of the femur. Number 3, not quite seen in the ultrasound image here, but that is the hidden trochlear cartilage. As you can see, it's overlaid here in the cadaver slice by the patella, and here partially overlaid by the patella here, depending on the flexion of the knee. And dynamically positioning the knee to show the maximum amount of fluid is something we'll cover in the live scan, but it's very beneficial to put this knee into slight flexion quadriceps tendon, which we already covered. We also have a quadriceps fat pad, this little triangular wedge here. So I prefer cadaver anatomy references over illustrations. For example, if you look back at some of the older illustrative knee diagrams from more prominent illustrators in anatomy, you'll notice that these two fat pads are virtually swapped out, where number 6 is quite small in some of the illustrations of the past, and number 5 here is quite large. So go back and take a look at some of those references and see the difference between cadaver and show how accurate ultrasound actually depicts this anatomy here. So the prefemoral fat pad is this large guy here, just enveloping the distal femur, and then all of this fluid here depicted up in the recess of the cadaveric image, but not in the ultrasound for some reason, is the suprapatellar recess itself. So this does communicate all the way into the knee joint under the patella, and it's not isolated as some sort of external bursa. Let's talk about cartilage and what it looks like in a normal case. You can see that the surface of the cartilage is nice and parallel with the surface of the distal femur. For example, if we did see damage here, I would see soft tissue structures dipping and herniating towards the cortex of the femur. So this is normal where the arrows are pointing it out. Long axis, and then short axis, we can see the sunrise view that you traditionally look at for radiography. We actually see the cartilage really nicely underneath the quadriceps tendon and transverse. Just a quick scanning note, we'll cover this in the live scan, but I can tell just by looking at this image, this is medial and this is lateral. So I can tell that because the vastus medialis is a large muscle mass that extends far more distal than the vastus lateralis not seen in the image here. So just glancing at the image, you'll always be able to tell that this is vastus medialis versus lateralis, as well as this trochlea here on the lateral aspect of the epitrochlea is always more superficial than the medial side. Medial side is always deeper, and the lateral side is always more superficial. And that's really important for your knee injections, for your needle guidance, so that you go proximal enough to avoid smacking your needle across this cortex on the lateral side of the knee. So there's your normal look at cartilage. Now let's look at abnormal. If you see kind of a delamination mid-layer between these layers of the trochlear cartilage, then you have an issue. You have to scan further. You have pathology there. But this was actually an injury, a contusion of somebody coming down on their knee and probably delaminated some sort of cartilage interface there. Here we have CP, the calcium pyrophosphate crystal deposition, all within the cartilage. Okay, so it's not coating the exterior part of the cartilage; it's on the internal part of the cartilage. So this would be more of a pseudo gout versus actual gout. So what would an osteochondral defect look like? Basketball player, young, high school, constant patellar dislocations, and acute injury here causing an osteochondral defect coming down on his knee. So there's no telling exactly what the undersurface of the patella looks like here. It's very hard to image with ultrasound. That is a limitation of ultrasound, so don't hang your hat on looking at the cartilage underneath the patella, but we can see pretty much, depending on how the knee is positioned, we can see most of the trochlear cartilage of the femur. And this is what an osteochondral defect would look like after an acute injury. Okay, next slide there. So also an acute injury, when you see blood coagulating and causing a fluid level within the suprapatellar recess, we can see this was a injury of somebody who fell on ice, slipped and landed on their knee. Everybody just seems to land on their knees. And what we have here is a fluid line between synovial fluid and blood. And as if we were to let that rest for quite a bit, you would see a linear line right across the joint line, wherever gravity would have that settle. But as of right now, fresh, probably 20-30 minutes after the injury, you put the transducer down and we can still see that blood all throughout the articular joint fluid there. A simple effusion will just be anechoic or 0 echoes, very easily compressible, and you should expect just the typical synovial fluid on aspiration. Here's a needle. The focus of this talk is not necessarily to go over all the knee injections, but this would be the traditional approach. This would be lateral to medial by ultrasound. All right, so before we go on to the infrapatellar tendon, we're going to break out and scan real quick that suprapatellar recess and the quadriceps tendon. All right, hoping my audio is still coming through good. But we're going to get started just on the suprapatellar recess. I like to scan with the cable wrapped around my wrist. Not only will that help us with the camera angle here today, but it keeps things from pulling and tugging on your transducer as you're scanning. So as I'm scanning suprapatellar, I always start with the distal portion, which will be screen right of the transducer on the patella, and I don't really let it leave the patella. And then I fire the thumb orientation marker, which will be the left side of the screen, towards the rest of the femur proximally. And then when we get into these dynamic maneuvers, I will traditionally place my palm down here on the infrapatellar tendon. Just kind of noticing a camera shift might help you guys see a little bit better. There we go. Sorry for the delay. As it would happen, right? All right, so I'm placing my palm on the distal portion of the patella, and then I'm just going to rest the transducer, and you notice my fingers are back here laid down on the rest of the leg. And that will help me not compress any pathology that might just be immediately visible. So if I were to start by just mashing down on the tissues, I might collapse a joint effusion, and I don't want to do that either. So let's get an arrow up on the screen. Here we go. And start pointing out some anatomy. So right up here would be my palm, transducer side, way over here. And then here's the cortical landmark of the proximal patella. And we always start with bones and musculoskeletal ultrasound because the soft tissue can change. So here's the distal femur. And I can't see the distalmost trochlea because it's overshadowed by the patella. So I can't see through the patella, it casts this shadow, and therefore I can't see the rest of this prefemoral fat pad, for example. I can't see the distal femoral trochlea and evaluate the cartilage in this position. And when the knee is more relatively straight, this is about a 20-degree flexion, some of your quadriceps inserts can appear hypoechoic and diseased. And so to eliminate that, what we're going to do is just have our model here slowly flex her knee up like this. And notice that I kept my palm on the patella, okay? By keeping my palm on the patella, I was able to kind of chase that patella with the transducer and not lose it. And we're going to keep our model's knee extending up even higher. And just like you saw on the slide, here we are. So we've got that tendon now in maximum tension, and that's going to help us identify any retractions in these layers. And then as mentioned, a lot of times on most people, you can notice these little facets on the patella, and they'll delineate, hey, this is rectus femoris. This is that blended layer here between the lateralis and medialis, and then the deep layer here would be intermedius. And then when the knee is in this maximum flexion, we can really see that hyperechoic quadriceps fat pad. Very important underneath that, especially in this position, not to call this a joint effusion. This is just cartilage. This is anechoic. It's not compressible if I give it transducer pressure, okay? That is not compressing that. It is what fluid would look like, but fluid would be compressible. And then this is the chondral or the cortex of the distal femur trochlea, okay? So if I were to take this shot here and now go short axis, I'll slice through the quads. We're going to lose the patella. In fact, let's start on the patella. I'm going to go left side medial, rotate the transducer, and let's look at the very enthesis of these tendons. So if we did suspect anything like a tear, calcium, especially calcium deposits. I see bone spurs here all the time, especially in long-term runners, degenerative changes. Tendinosis always occurs, it seems, right here at this most thin line. That's where I'm starting. So what I'm doing now is you'll notice I sweep the transducer proximally. I lose the tendon fibers. They're turning anechoic
and that's that anisotropy artifact that we covered in the shoulder workshop. But watch when I tilt the transducer. Those fibers should fill in, okay? Cool thing about that artifact, it really only works on healthy tendons. So if I were to tilt back and I get a completely anechoic tendon like that, that's a good thing. That means this entire quadriceps is healthy. If I start to see little invading hyperechoic homogeneous portions of the tendon that do not respond to angle artifact, you should be highly suspicious of those being some sort of tendinopathy. Because once the tendons lose their linear, longitudinally arranged fibrillar appearance and they start to blend in a homogeneous way that's dark and hypoechoic and diffuse, that's when tendon disease is easy to pick up. So nice healthy quadriceps tendon here. It's this oval. Here's the fat pad underneath it, the quadriceps fat pad. And I'm going to climb more proximally again. Here we have the distal femoral trochlea. And then right off the bat, check it out, I can tell again, left side is medial. I always see that more distal musculotendinous portion of the vastus medialis, oblique. And then lateralis hasn't even come into the shot yet. It's all tendinous, okay? So if I were to turn my probe a little bit here and climb laterally, I could evaluate the quadriceps tendon of the vastus lateralis more proximally and laterally over here. So I'm going to go back over to the main quadriceps, right over the distal femoral trochlea, and this looks like that sunrise view that you get in radiography. And we can keep evaluating that proximally and distally. If we wanted to evaluate more of it, we could put the knee into a little bit more flexion. And any further distal, I'll show you a cool trick in the infrapatellar exam. We can further evaluate the rest of the anterior part of the trochlea on the infrapatellar view when we straighten the knee, and we'll go over that in just in a minute. Things I'm looking for is the parallel nature of this cartilage, okay? I don't see any divots in the cartilage. I don't see soft tissue like tendon or fat trying to herniate through the cartilage. I don't see the crystal deposition that we saw in the PowerPoint. And the cortical surface looks nice and smooth and continuous. I don't see any erosive looks. I'm letting up on my transducer pressure to make sure there's no fluid collection above the cartilage. Now let's travel more proximally. Now that I feel good about the cartilage and the quadriceps tendon integrity, I'm just going to have our model straighten her knee out, relatively speaking, to that more 20-degree flexion. Okay, I'm going to hold the leg here, and passively, let's take a look at the suprapatellar recess and its various ways we can identify it. Because here today we have a pretty dry knee, and this can be very frustrating in your knee injections. And we will have a more comprehensive knee injection demonstration with a guest speaker later in the year. But I do want to show you a few tricks that you can do to access the knee joint. So here I can tell this is prefemoral fat. This is the quadriceps fat, this little triangle here. And then check out this sliver of a hypoechoic line right there as it climbs up proximally underneath the quadriceps tendon here. This is the suprapatellar recess. And we can tell that dynamically just by doing more passive flexion and extension right there. I'm getting those two fat pads to oppose each other, okay? So right there, we even force a small triangular wedge of joint effusion. And then I always find that slightly more lateral of midline, more lateral, I catch just a bit more of the suprapatellar recess than if I were to hang the transducer over medially. Okay, so dynamically, that's one way to tell where the suprapatellar recess is in a dry knee. Another way is to have the patient actually tighten their quad. And you can see that same recess, and oftentimes this tensioning here of the quad tendon will pull up and cause kind of a syringe-like vacuum and actually pull some of the fluid into the suprapatellar pouch. So we don't see that here today. Normal healthy knee, I think we saw that in the cartilage exam. Go ahead and relax. Other ways we can evaluate for where that recess is for needle target location is to go short axis, okay, left side medial. And you want to get away from the cartilage here because we're gonna tee up for a joint injection, right? So here's the quadriceps tendon. And remember, in that cadaver slice we saw immediately beneath the quad tendon when we're proximal to the quadriceps fat pad is the suprapatellar recess. And I still don't see it here in short axis very confidently. But if you palpate the IT band and just poke a little above it with your finger, okay, we're causing this medial lateral motion of the prefemoral fat underneath the quadriceps tendon here, and we're going to identify that synovial recess right there where my arrow is. And that's just one other way to identify it. If I bring my probe out even more laterally, I can kind of see sometimes a joint effusion kind of wrinkle up over there laterally, but not today. And then the fourth way is really to sonopalpate. We're going to push into the quad here with the transducer and get that fat pad to displace medially and laterally with my pressure. And there I can further delineate, hey, anything that's mobile is fat. So we wouldn't want to call this part right here, that's not the joint recess, that's part of the fat. It's a little oil dense pocket. It's part of the fibroadipose tissue. And I can tell that when I squish, it's mobile and it all moves. So it's the interface above that right here. And we're causing just a slight bit maybe of the effusion to leak out into one little interface there. But she doesn't have an effusion. So what you would want to do there is just drive your needle right under the quad laterally in this direction here. Drive your needle above the IT band right here. And then we're going to aim slightly towards the transducer. Okay. And then we're just going to drive the needle from lateral to medial and plop it right there under the quad. And then give a test injection. If the injection were to ball up and blister up around your needle, then you would be missing the knee joint. You would be in the fat pad. That injection should spread from medial to lateral in a vacuum plane. So very important to identify that it's not collecting around your needle to verify your location in the suprapatellar recess. Medially, let's come over here medially to the vastus medialis oblique. Okay, and then it's bordering some of the superior retinaculum, the patellofemoral retinaculum here. So we can see the patella medially, going a little bit off the slides here, but here's that retinaculum, and you can see how far proximally it extends underneath the VMO. So here's VMO, here's more of the retinaculum, and it'll go all the way over here to the adductor tubercle, which we'll get into on the medial part of the knee later in the month. So VMO is a really cool one to image, especially in front of your patients, because it just looks like a big piece of meat. And here in short axis, you recognize that the fibers are going from proximal to distal, but not straight up and down. They take an immediate abrupt curve up towards the patella. And this is a cool image to teach musculoskeletal ultrasound, especially to beginners, how to follow fibers in their short axis and follow them as they traverse through their planes. But I'm looking for volume loss, I'm looking for divots and soft tissue mass, herniations from the superior portion and the inside. I'm looking for irregularities, and I just don't see any there. Long axis, you can see where I am in short axis, relatively speaking. I'm going to go this way and just turn the probe oblique there, and we see really, really nice longitudinally oriented fibers of the VMO. It's one of the more awesome muscles to image in the knee, just because it's so prominent. It's such a medial landmark. It kind of tells you where you are. Now we're going to go over here laterally. We're going to roll the knee over. Same logic applies. We're going to look at the vastus lateralis now, this more superficial bipinnate muscle right here. It does taper off much quicker. Here we go. And I'm just going to rotate the transducer long axis to it, and it has a much longer musculotendinous junction than the vastus medialis, which was a real short, stumpy musculotendinous junction. But you can see my transducer plane and how lateral it is, upward sloping towards the patella. Here we go. Here's the vastus lateralis, and you can see its central tendon and its bipinnate feather-looking classic muscular architecture here. All right, and then last but not least, vastus, well, not last, actually we still have rectus femoris to kind of cover, going off slides again. But here's your rectus femoris, this oval shaped structure here, kind of sits like an hourglass on top of the vastus intermedius. So this structure here always kind of reminds me of this big hourglass landmark, or a figure 8, where we see one on top of the other. If you're evaluating for atrophy, I will say don't go off of one slice when you're comparing this this muscle to its surroundings. They run at slightly different angles, okay? So if I'm cutting the rectus femoris in short axis perfectly perpendicular, that means your vastus intermedius is at a slightly different angle unless you're really compressing the two together. So you have to tilt, and you'll get the distal more the deeper vastus intermedius here, you'll get it to highlight really nicely over the femur, but not all the time will you get the rectus femoris to highlight really nicely there. So it's one or the other. So vastus intermedius, we're looking at it here. Nice short axis, no atrophy, no muscle injury, good lean muscle. I'm going to tilt the probe and show the rectus femoris in a similar fashion here. So that's how you kind of navigate your way through these quads. And there you are, you can see that quad nature. So here we have the 1, 2, 3, 4 all in one slice. It's a 50 millimeter transducer head. It's already very wide, all the way from the shallow part of the image to the deep part of the image, so we can capture all these in one shot. And we'll have to keep your questions for after the next portion. We're going to go over the infrapatellar next. Hang on to your questions, and we'll answer those right after the infrapatellar portion. So I'm just going to make a switch over to presentation and go there.
All right, we'll get going with the infrapatellar tendon. This should be pretty quick, and then we'll get back to live scanning and answer your questions live if you have any. So have them ready. Type them in the chat portal as we come to a close on the live scanning portion, and we'll circle back around and be able to answer your questions live with scanning if needed. All right, so infrapatellar tendon, very straightforward. Probably my favorite tendon to really show beginners where to start scanning, because you can easily palpate your patella and you can easily palpate the tibial tuberosity. So it's only natural to set the proximal aspect of the probe over the patella and the distal aspect of the probe over the tibial tuberosity and expect to see a tendon. And it's fairly straightforward. So from there, it's just a matter of, proper angulation, making sure you're very thorough, sweeping the transducer medial to lateral, and we'll cover those scanning tips in the live scan here. But let's go over our bony landmarks first. So number 1, we have the distal patella. Number 2, we have the tibial tuberosity. Number 3, we have the infrapatellar tendon, this big guy right here, like a classic tendon drawing on illustration. And then distally here, most of this is overlap. It's a quite a large transducer. 50 millimeters will capture all of the body of the tendon. If you were to set the probe right down the middle, the image would begin about here and end about here. But I think it's important when describing this anatomy to show the very, very most origin of the patellar tendon right here, and the distalmost enthesis and how far down the tibial tuberosity it actually goes. A little trivial question here, why do we call this a tendon if it appears to go from bone patella to bone tibia? And just depends on, I guess, how you were brought up, tomato tomato kind of thing, or how you were taught. But some schools of thought would consider the patella a sesamoid, and that would make this an extension of the quadriceps tendon. So we have the patellar tendon just being an extension of the quad, which is enveloping as a sesamoid the patella, classifying the rest of this structure as a tendon. If you would consider the patella an independent bone, then we have a bone-to-bone connection here, and this becomes the infrapatellar or patellar ligament. Either way is fine with me. I just think it's fun, and it was fun when I learned this to show that distinct difference. And I will say ultrasound makes it really fun, because if you, and we'll do this on the live scan if you want, but if you were to follow this really thin hyperechoic line right here, the superficial most aspect of these fibers, proximally all the way to the quad, and almost seen on this MRI, they tend to fade off right here. You would notice that a lot of these fibers are contiguous with that most superficial portion of the quadriceps, further strengthening that relationship of this being a large sesamoid protecting the distal femur and an extension of the quadriceps tendon. So if that's the case, we have strong evidence of that on ultrasound, and less detailed on MRI, but when you really look at it on ultrasound, it's really neat to see that communication. What happens when things go wrong in that area? So we see a lot of acute patellar tendinosis, tendinitis, which is imaged over here with the color power Doppler. I can't emphasize enough all the pathology that you find in MSK ultrasound. Throw on your color power Doppler, it's very important. Here we're showing a feature called color compare. So if you're doing procedures, or you just want to go ahead and get that simultaneous image with and without color live at the same time, and we can do that on the live scan as well, this is what it'll look like. But here we have this anechoic part of the tendon. No matter how I tilt or rock the transducer, it's not filling in. Previous webinars, we spoke about the artifact called anisotropy, which is angle artifact, where if a tendon is oblique to the transducer, it just does not reflect the fiber angle back to the probe. So very important to know about that artifact, and that's not what we're seeing here. If we were to press down on this, it would probably collapse this small partial tear. These tears typically occur on the undersurface of the tendon, not necessarily superficially. Not very often at least, but I tend to see more jumper's knee pathology right there on the most posterior surface of the tendon, right at the distal patella. Throw on your color power Doppler to confirm that. There are a normal group of vessels that just line the underbelly of the tendon here, but they typically don't invade the architecture of the tendon like we're seeing here. Also note the fiber geometry that we're seeing here looks more like a loaded paintbrush than a normal tendon. So underneath, let's just take a look at this older picture here. This is a normal patellar tendon, distal patella. Note that the fibers are nice and parallel with each other. The posterior surface and the superficial surface of these fibers are nice and parallel. And you come over here where we have tendinosis, and you notice that these fibers tend to fan away from each other because they're loaded with fluid or degenerated architecture that no longer is longitudinally oriented fibers. So within the structure here, we have a loss of fiber detail right down the center of the area of concern. Surrounding that, we have normal fibers, which is good, but we have this diffuse echogenic pattern right down the core of the tendon, leading all the way up to the tear site, and that would be consistent with tendinosis. We've lost our fiber architecture. If we did see normal fibers, but they were not, if they were normal and loaded with fluid, we'd call that more of a tendinitis. Coming over here to more just an undersurface patellar tendon tear, very common. We see a little calcium there. It might have been a fleck pulled off through an avulsion. We also see that here in long and short axis on the bottom right. So always confirm these in short axis, and we'll do long and short axis scanning in the live scan. Thank you very much. And while we get switched over on video, I just want to remind everybody we have medial and lateral knee evaluation coming up next in the series. It's a three-part series. We're going to cover medial lateral because they scan very similarly. We will cover dynamic valgus varus stress maneuvers and how to stress the knee and those limitations. So you want to look at meniscal pathology. Is that easy to see? Is it not easy to see? Where are the limitations? Where are the strengths of ultrasound? I think it's very important to have that conversation. And then also be aware that we're going to have a posterior knee probably in the coming month and a half. We don't have the medial lateral date posted just yet, but be checking your email, checking social media for that date. I'm going to turn it over to the studio now, and we're going to go with the live scanning demonstration. So if you'll just give me 1 second to get that set up, we'll get started on the live demo and your questions.
All right. Make sure our microphone's on. Good audio. And as mentioned before, medial and lateral scanning, a little bit different, a little more difficult, but infrapatellar, my favorite part to teach, basically because it's so easy, especially for beginners, to understand the concepts of MSK ultrasound. We have just the easiest longitudinally arranged fibers there are in the whole body, easy to reach on yourself if you have a machine at home. I will say what I like to do is I hang a finger down just underneath the transducer. So I want you to get a look at just the scanning technique for doing superficial structures. And that would be to just hang a finger underneath the probe, and we're going to pretend it's like a stilt. We did this a lot in the wrist webinar. If you didn't see that, go check that out for those compartments on the wrist. But I'm hanging my finger down right underneath the probe, and I'm palpating right next door to the tibial tuberosity. And what that does is allow the transducer to rest right on top of there. And the reason that's so important, let's go superficial with the ultrasound image. The reason that's important is there's a few bursa that live around this area, and we don't want to compress them. So let's kick it off with just a little bit more gel right over the tibial tuberosity, up towards the distal patella, and I'm going to use my fingers as a stilt there. So superficially, we have the gel, then we have the skin line, sub-Q. Here's the patellar tendon right here in long axis, looks good. Here's the tibial tuberosity. Not discussed in the slides, but we'll discuss now, is the presence of a superficial infrapatellar bursa right here. And we don't see that in normal cases. Unlike the suprapatellar recess of the femur, we don't see these bursa unless there's something actually wrong. There's also a deep infrapatellar bursa that lives just deep right above the tibia, and I will see those. There's a little bit of a sliver. I will see those in cases that are normal as well. So just sometimes you'll see a sliver of fluid there. And the thing to note is the fact that I'm not compressing it because I have so much gel built up. But I don't see a synovial thickening or a big thick rim around this lining. So I don't see any synovitis. It's just a slightly simple effusion of that bursa. And the big deal is that we're not collapsing the structures. So what you don't want to do is always just lay your gel down and then just slap the probe right there, because you're going to collapse that superficial infrapatellar interface. And we're trying to avoid that. So next structures to look at is that jumper's knee. And we're going to point the camera down just a touch there. So here we are superficially and proximally at the distal patella. And we see the patellar tendon's bulk of its origin. And then I mentioned that you can chase those fibers proximally all the way up over the kneecap until they meet and marry up with the rectus femoris layer, at least in this slice. Medially and laterally, you'll see some similarities of the aponeurosis too. But right there is definitely a thickening of the contiguous fascia that envelops the kneecap and blends with the rectus femoris layer. So you can actually see that communication, and injuries can happen up here. So if it's very tender, don't rule out some sort of quad pathology, okay, or infrapatellar pathology if it hurts either way. What I'm going to do just to rule out another zone of bursitis, which is called a prepatellar bursa, that lives just right where my arrow is, right above the infrapatellar tendon, right under where the arrow is. And we did see that in that last slide. And then another trick for doing a gel standoff is to find the area that you suspect right there. And I'm going to lift my transducer up like that. And then right in the skin, I can see a shiny absence of gel in a rectangular form, and that's where my probe lifted off. So that's where I'm going to put a bead of gel, just like that. And then I'm going to do the same trick where I'm hanging my fingers underneath the transducer like this. And when I hang my fingers underneath the transducer, I'm not collapsing the prepatellar bursa. And I have a lot of scanning stability. I'm trying to keep the cord out of the camera view. I have a lot of scanning stability without squishing the subcutaneous layer. So here's where I would be looking for that prepatellar bursitis to live, okay? It may be a little more difficult to use color power Doppler in this case with a gel standoff because there's a lot of motion artifact that's set off in the gel. So if you do suspect one of those, you may have to slightly touch the skin and kind of dampen those areas of motion where you can and set your wall filter settings accordingly. But here's a normal patellar tendon origin. Arguably, you could say we're losing a little bit of tendon architecture on the deeper surface here. Like, I don't see the longitudinally arranged fibers so much, but it's not dark. It's not full of tendinosis. So we are ultrasounding an avid runner as our model here today. So we just want to keep an eye on this area right here on the undersurface where I see a lack of fibrillar detail. And then to confirm that, what we do is we just switch over to a short axis. We cut the patellar tendon in short axis. Left side will go medial again. Start up at the patella. So here's the origin at the patella. And then I'm just going to climb off the patella towards the tibial tuberosity. And I see maybe a thinning down the middle where there might have been more tendon architecture on this undersurface. So it's just something to watch out for. Maybe there's a forming of a tendinosis right here where this looks more homogeneous than the surrounding kind of hamburger patty look of the patellar tendon. I've also heard it described, which I think is really good for an anisotropy slide. This is like we're looking down the bristles of a paintbrush. So watch me tilt the transducer and let's look for healthy fibers to disappear. And I don't see any of the abnormal fibers that I would suspect in tendinosis to be sticking around in a homogeneous brighter hyperechoic fashion. So I'm going to tilt the probe both directions. I think it's easier when you just tilt the handle towards the head. Yeah, getting a lot more anisotropy that way. So just tilt the handle towards the head, and it just helps you scan throughout that tendon. Again, distally, checking out the distal portion, short axis, like that. Build up your standoff. Use your fingers as stilts so that you're not compressing the superficial infrapatellar bursa or the deep infrapatellar bursa. Give that a shot. And then remember, we're going to see a little bit more of a bursal effusion there laterally, which we see right there. That one sliver of a deep infrapatellar bursa is showing up just in this lateral corner. So simple fluid collections do compress. So we're just going to provide a little compression. And then next to it, I see some dark structures here. I know them to be vessels, but how do we know this isn't a vessel, right? So let's just check our work and hit the C button on the color feature and see if it lights up. And the bursa is not lighting up, but the lateral inferior geniculate structures are. And yes, you can map those out very nicely on ultrasound. So here we go. I also promised a distal look at the anterior trochlea. So underneath my arrow is all Hoffa's fat pad, but it's not all. That's not all there is to look at. So what I'm going to do is just fire the machine's depth a little deeper until I see some cortical structures. And you can see that I'm already aiming my beam into that distal trochlea. Here we go. So there's the rest of that sunrise view. Okay, so we can see that nice hilltop looking sunrise view here. And then just keep in mind, all of this is Hoffa's fat pad. Laterally, I don't see any big joint effusion following the cartilage, and medially I don't see a big joint effusion following the cartilage. So this also will take us and segue us into a talking point of why do we use ultrasound guidance for a knee joint injection. One, we can stay away from cartilage. Two, the blind landmarks are not quite as obvious as you would think. If you look at all the literature, the approach should be that her knees are hanging off the side of the table. You place, you don't even use a transducer in a blind approach. You palpate medially and laterally. You feel that Hoffa's fat pad on either side of the joint line, and you drive your needle. Some people go ahead and hit a little bit of bone and back off. That bone you're hitting is the cartilage, and we want to avoid scuffing the cartilage if we can, because you're probably going to inject some sort of corticosteroid. And corticosteroid over a cartilage scuff is not good for the cartilage. So let's avoid that and look at the confidence we can have with ultrasound. There's a published technique to come in this view laterally and to slip the needle just over the cartilage and inject. And they show that if it balls up around the needle, it's a miss. If it follows the plane of the cartilage, then it's a direct hit of the recess, which is true. But they also only went to that approach if the lateral gutter of the suprapatellar recess was dry. So those authors did specifically mention only to go infrapatellar like this when suprapatellar didn't have confidence. So suprapatellar is the preferred approach, and I gave you 4 options to find a dry recess. So there's really no reason to come down here. I haven't seen this taught in any major workshops or courses. I don't know of anybody personally that injects this way. I just want to give you that as just a thought-provoking anatomic discussion of what all we can see here as we're on the anterior, more inferior part of the trochlea here. And distal, deep part of the image, you can see that divide into the 2 condyles of the knee. So just to give you an idea of just how deep we are seeing, I don't see that big anatomy illustration of a big bag of fluid that you see hanging on the doctor's office's wall for the knee. I always see this huge bag of fluid that they're injecting or aspirating, and it's always infrapatellar. And I can say I've never seen that with ultrasound. So I always see that big bag of fluid up here in the suprapatellar recess. But that's about all I can go on and on about the infrapatellar and suprapatellar anatomy. And we'll open it up. We'll close the recording portion of this momentarily just for a clean recording. But if you did have questions and you've got them ready, type them in the chat portal, and Chris will go ahead and read those, and we'll get them verbalized here on the webinar, and we can answer them live. Let's try to stick to the topic of suprapatellar and infrapatellar if we can. And while we wait, shameless plug here to visit us at AIUM in San Diego. If you're an orthopedic surgeon, we'll be at AAOS in Chicago. So come by the booth and check out the Sonosite PX, which we're scanning with here today, or the newly released Sonosite LX, which is kind of a bigger, beefier version of the machine that we're scanning with here today. If you're not familiar with that, also check it out at sonosite.com.
All right, it looks like we don't really have any questions coming in. So I guess we'll go ahead and call it for this webinar. So I want to thank everybody for coming here today and listening to this presentation. Daniel is a very comprehensive look, and I'm sure everybody learned a lot despite the internet issues. So thank you very much. We appreciate you sharing your expertise with the audience. And thanks everybody for coming, and we'll see you at the next knee webinar. Bye-bye.
Thanks, everybody. Have a great